Welcome to Diabetes in 2019. My name is Paul Chous. I'm an optometrist in Tacoma, Washington. I have a practice that emphasizes diabetes eye care and diabetes education. Here are my disclosures. I'll do my darndest to try not to be unduly influenced by my associations with various industrial organizations and groups. So we'll talk today about some new things, some old things, some borrowed things, and some blue things. We'll start with a couple of blue phenomena in the diabetes realm. So worldwide now we have almost 500 million people that have diabetes. Of course, most of these people have type 2 disease, about 483 million currently. Half of all people that actually have diabetes today worldwide are undiagnosed. And the US is doing better with about 27% of people having the disease undiagnosed, but still it's a large percentage of the population. 5 million deaths were directly attributable to diabetes in the year 2017. And most of these, half of these, were in people that were young, under the age of 60. You or the person next to you almost certainly has or will soon have diabetes, or at the very least, prediabetes. So costs of diabetes care to the U.S. economy were $327 billion in the year 2017, and that's up from $245 billion in 2012. So that's about a 26% increase in diabetes costs after adjustments for inflation. So let's spend a moment talking about some new things, and that'll be, in fact, probably the majority of the talk. So the first thing I wanted to mention is the American College of Physicians came out with this updated practice guideline for type 2 diabetes, where they essentially said it's okay to let patients' blood glucoses remain high. In fact, for older patients, there should be no judgment of physicians for how good of a hemoglobin A1C patients achieve. And that if patients had a lower A1C, for instance, under 6.5, that therapy should be de-intensified. Now, as eye doctors, we know that's going to result in more diabetic retinopathy and more vision loss. And this completely runs counter to the recommendations of the American Academy of Clinical Endocrinology, as well as the American Diabetes Association. So just thought that was an interesting clinical practice recommendation from the American College of Physicians. So let's talk a bit about continuous glucose monitors. I'm going to talk about these devices that continuously measure patients' blood glucose. They have to be calibrated oftentimes, but they give patients constant biofeedback about their current state of blood glucose control. And we'll talk momentarily about each of these devices. So the first thing is the Dexcom G6 continuous glucose monitor, or CGM. It's a very accurate sensor. It's not affected, as are most of the other ones, by acetaminophen, and it's very easy to insert. You can use a single button. It's injected under the skin. It sits there for 10 days, and about every 5 minutes, patients receive a blood glucose measurement along with an indicator bar that says whether the glucose is going up, is going down, and how rapidly it's going up or down, or whether the blood glucose levels are stable. It's been approved recently for Medicare patients that are using insulin therapy, whether they have type 1 or type 2 diabetes. It's a little more expensive, though, than the next device, which is the Freestyle Libre device from Abbott. It's a handheld scanner. It uses what's referred to as flash glucose monitoring. Flash because it's not constantly giving you the reading. You have to hold a scanner over the device that's applied on the upper arm, and it gives you instantaneous measurement of blood glucose. It's calibrated at the factory, so it doesn't require any blood glucose calibration by drawing blood from the patient's finger. It's been approved for both type 1 and type 2 diabetes. It is a huge hit with patients that are on insulin therapy with type 2 diabetes. And it lasts for up to 14 days on the arm, provided it's not torn off by the user or by the wearer. And the interesting thing is that this recent analysis showed that patients that scanned their blood glucoses more frequently, in fact, achieved significantly better hemoglobin A1C. And we know that's going to result in fewer patients with diabetic retinopathy and hopefully sight-threatening diabetic retinopathy. This is the latest iteration of this whole idea, but it's a 90-day surgically implanted sensor that goes under the skin. It's injected, or rather surgically implanted under the skin, typically on the arm, and it can sit there for 3 months, doesn't require calibration. It, like the Dexcom device, is not affected by acetaminophen. Tetracycline does interfere with it, though, and it's been FDA approved The cost is about equivalent to the other continuous glucose monitors. The issue is that it has to be surgically implanted and then explanted after the 90 days. So a little more labor intensive. This is, the latest and greatest in insulin pump technology, the Medtronic 670G. So what this is a continuous glucose monitor that gives data to the insulin pump. The two kind of talk to one another, and the idea is that when patients are not eating, because when they eat they still have to give themselves insulin vis-a-vis the pump, but when they're not eating, the background rate of insulin is adjusted up or down depending on the readings coming back from the continuous glucose monitoring system. And they've set a goal to keep the patient's blood sugar at 140. That's what the FDA approved, because if it's much lower than that, the risk of hypoglycemia goes up, and the FDA didn't want to take that chance. I think it's an excellent choice for patients that have hemoglobin A1C above 7%, but there's a couple of issues. It requires a lot of work. It is constantly asking for calibration, and customer service from Medtronic reportedly has not been good with the demise of Johnson & Johnson in the marketplace for insulin pumps. And so that's something that you have to always be aware of, is how good is customer support. I think that this pump is going to get better and better as time goes by. Medtronic is a major player in the market, and likely their upcoming iterations of this kind of technology are going to prove to be better and better as time goes by. So here's some facts about continuous glucose monitors. So somewhere about a third of patients with type 1 diabetes in the US are currently using these continuous glucose monitoring systems. It's increasingly popular for patients with type 2 diabetes that are on insulin therapy, especially in the US. Worldwide, though, the uptake rate is pretty low, between 1 and 3%. And, these devices have been shown to reduce glycosylated hemoglobin about a point without increasing dose and with less hypoglycemia. So those are good things. It does increase the short-term cost of care, though, about $2,000 a year, roughly. So the question really is, why bother with this technology? And so I'll make the case for why I think we ought to be bothering with doing continuous glucose monitoring systems. So on the left is a picture of, the upper left is a picture there of a cell phone with the patient's glucose level of 202, and you can see the arrow pointing up, which means the patient's blood sugar levels are rising. On the right, we have a patient whose blood glucose is low. His blood glucose is dropping. We can see the down arrow. So what these devices do is they will alarm you as a patient wearing them when your blood glucose either gets too high or dangerously low, so that you can react to that phenomenon before multiple hours go by. So we have a graph there on the upper right just showing a patient with very unstable blood glucose measurements going up and down all over the place. And so what's really becoming key in diabetes management per endocrinology is what's called the TIR, or the time in range. And this refers to the percentage of the day that a patient's blood glucose levels remain within a certain pre-specified range, typically from 70 milligrams per deciliter up to about 180. That's considered to be roughly in range, even though for somebody without diabetes, it's not strictly all that great in terms of being in range. But we now know, based on some recent evidence, that time in range plays a huge role in the development of diabetic retinopathy. So why isn't hemoglobin A1C the whole story? That's what we've relied on now for decades. Well, these are three patients, hypothetical patients, that all have a hemoglobin A1C of 7%. So you can see the first patient is very high much of the day, very low a good portion of the day, and in range a smaller percentage of the day. Good A1C. The number two patient is in range most of the day, high some of the day, and low a small amount of the day. The third patient on the far right is in range the whole day. So these patients are going to have different life experiences depending on which group they fall into, and you can of course have hybrids of these groups. So if a patient is expending a lot of time in hypoglycemic range, even though their hemoglobin A1C may be good, the quality of life goes down. Conversely, patients that have really high and really low high and low blood glucose values throughout the day may have a good quote-unquote hemoglobin A1C, but blood glucose control that's really poor because it's so labile, so changeable. So the U.S. spent more than $1 billion in 2009 on hospitalizations for severe hypoglycemia. So hypoglycemia ends up costing a lot of money, and it can actually kill patients. There's a phenomenon called the dead in bed syndrome, where patients go to bed, their blood glucose has dropped too low, typically under 30, and their heart simply stops and they perish. So to correct that, now this is just something I wanted to throw in, and I think there's a CE question on this later, so forgive me, but there is now an application for nasal glucagon. Normally it has to be prepared and injected, but this new glucagon apparatus would allow you to snort it, basically sniff it in your nose, and get blood glucose levels elevated rapidly, and this could save somebody's life. So back to continuous glucose monitoring, though, in time in range. So the time in range that is typically used now by the people doing the research on this is between 70 and 180. If you're under 70 or below 180, you're out of range. And now these continuous glucose monitoring systems have software that will actually measure a patient's percentage of time that they're in the normal range. Here's why it's a big deal, this bottom bullet point. A 10% decrease in time in range increases the risk of diabetic retinopathy getting significantly worse, or of developing in the first place, by about 60%. And this is based on a post hoc analysis of people from the Diabetes Control and Complication Trial who were measuring their blood glucoses by fingerstick blood draw multiple times a day. And that's a really big deal. So let me make the case for why that might be a big deal. So here's a typical patient, moderate non-proliferative retinopathy, has had type 1 diabetes for 10 years. The hemoglobin A1C is reasonably good at 7%. The patient's time in range between 70 and 180 is 60% of the day. So that's 14.4 hours. So let's say we wanted to try to reduce this patient's risk of developing sight-threatening diabetic retinopathy, or STDR. So there's a couple of ways we could do this. One is to conventionally lower the hemoglobin A1C. And to effect a 40% reduction in progression to either diabetic macular edema or proliferative diabetic retinopathy, the hemoglobin A1C would have to be reduced to about 4%. Now that's virtually impossible for somebody with diabetes without provoking profound and chronic episodes of low blood sugar that could threaten a patient's life. It's just not doable. But using this time in range calculus, if you can increase the time in range to 73.6%, up to 17.6 hours a day, you're getting the same 40% risk reduction in progression of the patient's moderate NPDR to a more severe disease state that immediately threatens vision. And this is going to be particularly beneficial when patients have a reasonably good hemoglobin A1C, when it's reasonably low, let's say under 7 or 7.5, but also when the time in range is also quite low, let's say 60% or less. Most endocrinologists are now saying if you can get your time in range above 72%, that seems to be the most advantageous in terms of developing micro and macrovascular complications of diabetes. So here's the result from the Dexcom Clarity app showing this patient was in range 87% of the time during this particular time period, which is only about a week. So you can do it for a week, a month, 3 months, and of course, the more data that you gather, probably the more useful it is. Same kind of idea from the Medtronic Sugar IQ app that uses the IBM Watson platform. And not only does this tell you your time in range, this particular patient's at 71% on the little right bar graph there under Sugar IQ Insight, but it also makes recommendations about blood glucose control at various times of day. So it'll detect patterns like your blood sugar is always high at 3:30 in the afternoon. You might want to pay attention to what you're eating or give yourself more insulin, so on and so forth. Here's another way to increase time in range other than monitoring it, which is really the best way, which is to use inhalable insulin. Afrezza, which is basically an inhaled insulin, it was compared to Novolog in type 1 diabetes, and it was shown to improve the time in range about 90 minutes a day. So if you're looking at the total number of hours in the day, that's about a 12% increase in time in range. So that might be a big deal. This particular insulin is not very popular in the United States. I tried it for about a year, and the problem was it was irritating to my lungs, causes you to cough, because the alveoli are really sensitive to having something, introduced into the lung. What I've had better luck with is something called FIASP, which is fast-acting insulin aspart, which is Novolog in an injectable form that works about doubly fast as conventional Novolog. So it brings the patient's blood glucose levels down very rapidly compared to other injected or pumped or even inhaled insulins, and it's a way to restore yourself into being within the time and range if you use this insulin rather than conventional insulins. So time and range with a hybrid closed loop. This is another product that's not quite yet approved by the FDA. It's made by Omnipod, another insulin pump manufacturer. So they showed that with their particular algorithm, they could improve time and range by almost 3 hours a day, not changing the average blood glucose and not really affecting anything in a negative